I also want to spend a brief period of time just going over what Dementia CareWare offers. So just for those of you who don't know the program yet and maybe found this program through this webinar opportunity, we do have a lot of online training modules. We have also the ability to do live trainings on our topics. We have podcasts. And so we just have a lot of training opportunities around dementia. We particularly tailor this to primary care. The goal of Dementia CareWare, if you've seen our tagline, is early detection leads to better care. Don't know, but I certainly hope that'll be part of our conversation today, if we have time to get to it. And so please just reach out if education and training around screening or other aspects of dementia are of usefulness or interest to you and your organization. We have a warm line, so for direct. We also have practice support. So we're increasingly working with clinics and practices to embed dementia screening and dementia care pathways into the care that they're providing. Hopefully you can see the QR code and find our website. Also, you can just type it in if you want to learn more about us and get in touch with us, dca@ucsf.edu. I always start with a brief overview of our approach to screening. We teach on something called the cognitive health assessment. It incorporates validated screening tools, which you're probably really familiar with, but it's really an approach, and it's an approach that is meant to be an annual brain health or cognitive checkup for older patients, particularly, and those who do not already have a diagnosis of dementia. And it starts with a brief history, a question or two about how that person is feeling around symptoms related to cognitive areas, then goes to validated screening tools for cognition and function. We always talk about how dementia is really tied towards cognitive impairment leading to functional decline. And then finally, we encourage a checkup on if that person has a caregiver or someone in their life who's part of their care. And that's part of our screening as a result. We also now increasingly have more and more opportunities and educational materials on a care pathway. So how can we go from early detection, thinking about a population health approach, to a full evaluation of that person's symptoms and well-being, to making a diagnosis, and ultimately to having a care plan and revisiting that care plan very frequently and having that guide your care. I just wanted to let you know about a sister program we have that also trains healthcare teams on how to identify caregivers and incorporate them into care. So in dementia, particularly, identifying, assessing, educating, supporting caregivers is so crucial to care. So we want to make sure people can have a place to get those skills. And that's where this program comes in. So you see our QR code if you want to learn more about that. And then also feel free to reach out to us anytime. And then finally, there's a new tool coming out in July that really helps. We have a lot of tools for advanced care planning on the medical side. This is really advanced care planning on the financial and legal side. So just want to make people aware of this new resource, Clarity. I'm leaving up the email of our colleague, Elizabeth Peters, here at UC Law, who's helping to spearhead this. And this program has a lot of educational tools, examples, guidance as well for specifically for healthcare teams to be able to connect people, caregivers, anybody who really needs it, with information and actual resources for legal and financial planning. And then finally, the Alzheimer's Association, which is a national association, of course, and has a 24-hour hotline, to support caregivers and people living with dementia on any aspects of care, as well as just readily available education and support. So want to make sure you know about their resources. Okay, so we were 10 minutes in, and we're going to devote the rest of the time to our esteemed guests and colleagues from the National Council of Dementia Minds. If possible, I would like it to turn it over to Erin Wallace from the National Council of Dementia Minds to tell us a little bit about the organization and also introduce us to our speakers today.
Thank you so much, Dr. Turtles. My name is Erin Wallace, and I am a volunteer with the National Council of Dementia Mind and get to spend pretty much every Thursday with a wonderful group of retired physicians all living with dementia. And some of them are here on the screen. Just a few words about the National Council of Dementia Minds. It is the first nonprofit in North America that is founded and governed all by individuals living with dementia, really embracing the whole thought of nothing about us without us. From their advocates and really have taken this by storm and are transforming the way that dementia is viewed and the way that professionals are interacting and supporting, and specifically with this group, really wanting to help transform that diagnosis process and support for individuals living with dementia. I'll turn it over to our guests here to introduce themselves, and I'm just going to go in order as they are on my screen. But first is Dr. Arnold Barish.
Hello, everyone. Thank you for being here. As Erin said, my name is Dr. Arnold Barish. I was diagnosed with MCI and early onset dementia in 2015. I worked as a podiatric foot and ankle surgeon, and of course, had my career ended in 2015 after diagnosis. I live in White Lake, Michigan.
Thanks, Dr. Barish. Dr. Langer.
Hi, I am a 67-year-old former neurologist who began noticing distinct cognitive symptoms at age 50 and wasn't diagnosed till age 60, despite multiple neurological examinations by cognitive behavioral neurologists.
Thanks, Dr. Langer. And last but not least, Dr. Schmidt.
Yeah, my name is Gary Schmidt. I'm a retired family practice physician living in Green Bay, Wisconsin. Practiced primary care for 37 years. 30 years, I was a medical director for a long-term care facility and was taking care of people with dementia. But I found out I really didn't know what I was doing after I got my diagnosis 6 years ago. And I've been diagnosed with dementia with Lewy bodies.
Hi, Dr. Dietrich. Just introduction. So if you want to share a little bit about yourself, where you're living, what type of dementia diagnosis is what others have shared so far.
Okay. I'm a retired neurologist. I've been on a 5-year journey trying to get diagnosed for the cause of my MCI with every test available, and there's been no conclusion as to the cause. I'm in Montana.
My name is David Compton. I have MCI as well. I'm a retired family physician, retired from the active practice of medicine. About 9 years ago, I was diagnosed. There was a delay in getting the diagnosis because, for lots of reasons, a lot of it is ultimately not getting to the right person at the right time, or people not truly paying attention to the symptoms I was trying to describe to them. I was being treated for rather severe affective disorder at the time too, so I think a lot of that got lost in there. Except the people treating me with the affective disorder said, no, that's not it. This is something else. So we finally got the diagnosis. There's too much delay.
Thank you, Dr. Compton. Dr. Charles, I'll turn it back to you to show the video.
Yes. So for everybody watching, we have a short video, about 10 minutes, that Dementia Minds has put together. And then Erin will moderate a conversation with the doctors we just met. And again, thank you all so much for doing this.
I'm Sarah Langer. I am a retired neurologist and was ultimately diagnosed with dementia with Lewy bodies.
My name is Arnie Barish. I'm a former podiatric foot and ankle surgeon. I was diagnosed with mild cognitive impairment with early onset dementia.
I'm Alan Schooley. I'm a pediatrician. I now have Alzheimer's.
Gary Schmidt, retired family practice physician, and now have dementia with Lewy bodies.
John Mahoney. I'm a primary care internist and also have done a lot of public health work, diagnosed with early stage Alzheimer's.
I'm David Compton, and I'm a retired family physician. I have Alzheimer's disease.
The physicians in this group had as much or more problem getting a diagnosis than everybody else. And it's like, holy shit.
Interesting. Everybody has these stories of their early diagnoses being so traumatic. And it's just confusing. And you're talking about a cognitive disorder. It's confusing for family, confusing for the individual, and unfortunately confusing for the healthcare professionals and industrial medical complex. That's tough.
The response was what I would frequently have told patients. Yeah, something might be going on, but it's not enough for us to catch.
I gave them a list of my symptoms, looking for just confirmation that yes, these symptoms could be from Lewy bodies. And basically, what I said was, "You don't have Parkinson's, and I'm not sure what to do with all these symptoms."
And it was a tough workup. Hey, I had all these well-meaning physicians here. You've got attention deficit, take this medicine, or you're depressed, take this medicine. Oh, you need to sleep more, take this. All those medicines make me worse. Everybody's wanting to give it time. Instead of saying, let's do some more testing. And finally, I got into who I see now.
All too often, doctors will, and this applies to neuropsychologists and all kinds of medical professionals, but they say, well, this person is not 2.5 standard deviations from the mean in their language function. They're not 2.5 standard deviations below the mean in their visual spatial function. They're not 2.5 standard deviations below the mean in terms of their memory function. Therefore, it's no big deal. But the fact is, in reality, real life translates into the summation of these deficits. And their families know that this is a change. But unless you got somebody strongly advocating for you, you're sunk.
When I was diagnosed, the resource that I was given when I left his office was, I know 2 psychologists on your side of the water that will help you deal with the depression that you're going to have. That was the resource that I was given.
Somebody came in and they talked to me and they said, you should do this and this and this and this, and then you do your what you can, and then just die. And he was like, do you want to die earlier or later? And oh, you shouldn't really do anything that's not, you don't like, and things like so it was sort of, that's about the best.
Actually, I part of my career, about 20 years, included being a physician on a dementia unit, which is obviously people with very severe, more end-stage disease. But what I never had at the time was a recognition of what can be done in early stage and progression. And I think that healthcare providers, including myself at that time, never had a sense of things that could be done or care that could be given along the journey. The medical mindset is at the end stage without consideration for those of us who still have something to do and to offer.
I have a cognitive loss. I have very early stages of Alzheimer's disease. But if I tell somebody I have Alzheimer's, they automatically put me in the in their head, put me in the nursing home, staring out the window, or independence, so I'm going, it's not like that.
When books or movies have been done about people with dementia or Alzheimer's, it's almost always looking at the terminal end of it. So that's the outlook that the public has towards it, that this is just a awful terminal disease.
So, it's always there. It's always been there, and always will be. And the question is, how we can change things to make it where people can survive.
People are afraid to diagnose it early. People are afraid to address their symptoms because they're afraid to get that dementia diagnosis. And that's a mistake, because this is a disease that can be modified. It's like when you think of somebody with diabetes, oh, that's unfortunate. Like, you use insulin, use pill. That's a disease. You get cancer. Oh, that's really bad. But now, in the 50s and 60s, they viewed cancer as that. Just don't look for it. Can't die. You can't do anything about it. Goodbye. So now, hey, it's treatable. We should take the same approach with these diseases.
If you have a heart attack, they automatically send you to all the right people. They have you see a dietitian. They start having you do exercise. They have all these things plotted out. They give you the medications. If you have a diagnosis of a dementia or cognitive impairment, I like to use the word cognitive impairment because dementia has this stigma about it. So if you have a cognitive impairment, there really isn't, but there's things that you can do.
So my recommendation is that upon presentation of a patient to clinic with cognitive complaints, a social worker or psychologist, an occupational therapist, a physical therapist, and a speech pathologist all be recruited to assess the patient for cognitive impairment and any other potential psychiatric or physical complaints that might accompany a neurodegenerative disorder. And I think it greatly enhances the diagnosis.
Pay attention to the early symptoms. If somebody comes and say, I'm really struggling with thinking through this, pay attention to that. Don't just say, oh, it's this, here's a pill. Man, in medicine, we've got to the point of where the classics, they train, well, here's a disease, here's treatment, then pharmacology. But with changes in the last 3 or 4 decades, it's disease, pills, then treatment. We've got it all wrong.
When I was first diagnosed, I looked at organizations that I could turn to, and the most frequent offerings were for the caregivers. The focus was on how do you deal with someone who can't function themselves. And I was really looking for something that told me how to function best by myself.
And that's what I think, what we're trying to do, with this group is figuring out simple things that can help people who have these diseases.
So we set up our support groups, but just people with it, caregiver. No anybody else in the room, just people with it, talk about it. Well, they have a lot to say.
Because they're people that have had life experiences like you have, living the same disease, and you can talk the same language and understand, see how they are functioning well in their environment. What we want to do as a group is somehow reduce the stigma of dementia and educate doctors, nurses, the general population, and what the disease is and how to respond to people when they have the disease. Let them know that we're still people. You don't have to be afraid of us.
What has drawn me to this is to how to live with Alzheimer's, not how to end with Alzheimer's.
Yes.
I will bring it back to the group. Thank you so much. That said a lot in a really short amount of time. But Erin, I'll pass it to you to take it from there. I, of course, have my thoughts and questions, but I'll wait to the end.
Wonderful. Thanks so much. So panelists, curious, what are items that you really want the audience to hear this afternoon? And specifically talking about the diagnosis experience, and perhaps maybe sharing items that were or weren't helpful for you during that diagnosis experience. And Dr. Dietrich, I know that you have a laundry list because you're still searching for that formal diagnosis, but wondering if I can turn it over to any of you to share some thoughts with the audience on this.
I'll
Go
start.
for it, Dr. Schmidt. Yeah.
Yeah. First of all, Dr. Alan Schooley, who you saw there, was with our group 2 years ago when this film was made. He was right. This is a terminal disease. He passed away on January 1st. Thing is, I had symptoms for probably 13, 14 years before I had the diagnosis. I had disrupted REM sleep. I lost my sense of smell. My voice went quiet. I had difficulty joining in conversations, especially in noisy areas. But it wasn't until I started having more functional problems with doing day-to-day things, remembering where I was, remembering names, that I finally sought help. But being a physician, I feel that I probably should have recognized all these things that lead up to it. And I've seen physicians during that time, and no one put it together for us.
Thanks, Dr. Schmidt. Who else wants to jump in? Go for it, Dr. Barish.
My diagnosis actually was fairly quick after seeing several neurologists and a neuropsychologist. The two physicians that saw me originally, I knew. So they kind of wrote things off as, oh, you're just too busy, you're tired, you just need to take a break. And my response to my personal primary physician was, when was the last time you took any time off? So it is as everyone said, it's a journey. You've got to keep pounding at it if you don't think it's right. And it is, I think it was either Gary or David that said, we all recognized that there were problems much earlier than we were diagnosed. Hindsight's 2020. And when I look back, I had been compensating for at least 2 or 3 years before I said something was wrong to my wife, and we then pursued getting a diagnosis.
Dr. Langer, I was thinking you were going to want to chime in on that.
I want to say a little bit about acquisition bias in diagnosis. And there's a great deal said about turning to care partners to give corroborative history. But I will tell you, in the case of my sister and myself, 2 of 3 sisters in my family have dementia with Lewy bodies. Actually, 3 of 4 sisters have dementia with Lewy bodies. That, our husbands were masters of denial and were not really forthcoming about our difficulties. And part of the reason I make the recommendation to get a social worker, a psychologist involved, and to get the occupational speech pathologist and maybe a physical therapist involved is because I think in the rarefied atmosphere of, the oversimplified atmosphere of a doctor's office or the neuropsychologist exam room, you do not get a real sense of what that person is capable of or what their deficits are. And I think that if someone had talked to my sister's coworkers, they would have been right on it about what her difficulties were. And I think that it's very important to get more sources of information. If either the care partner or the person involved say this is a significant departure from my previous level of functioning, I think you've got to get additional history somewhere.
Wonderful, Dr. Langer. Yeah, go for it, Dr. Compton.
Yeah, I want to follow up on what several comments here Arnie pointed out. I was also one of the first people I saw originally was a neurologist that was a friend of mine. There again, you don't want to see your friends because they think, oh, I was told this exact same thing. Oh, you're working too hard. And I was already struggling with a depression. And one of my benefits was my wife actually knew that, no, this isn't just depression. I was having too much, and a coworker too, that realized that I was struggling seeing patients in orderly fashion, keeping up with getting the Coumadin dose right when the RNRs were given to me. The little things. The little things are important. And to listen to the little things are important.
Absolutely. Dr. Dietrich, do you have anything to add?
Yes. Just because a patient passes the cognitive screen does not mean that they don't have impairment. You need to consider their premorbid status. In my case, I knew the cognitive testing, and 5 years in, I'm still passing the testing, even though it's decreased a bit. I'm still considered in the quote normal range in the overall testing. There's some areas where I'm impaired, but that needs to be thought about. What is the ability of the person to start with, and has there been a change? My wife noted changes in my cognition a few years before I became aware of them, but she's a brilliant psychologist. My first neurologist told me to get some hobbies. That was not an answer to anything. My fourth neurologist took me seriously and started doing testing and found abnormalities on a PET scan, but not enough to make a diagnosis of what's wrong. And I continue to follow up with them. So just because there's no answer doesn't mean come back in a year if there's a change. You need to continue to see the person and find out what's different in their life and what changes that they've noticed or their family has noticed.
Great.
In my evaluation, I saw my family doctor first, and he sent me for the neuropsych test, and I failed the clock test, which I had given to most people, to many people, but I got 99 percentile on the math. Then I saw the neurologist, and his exam didn't have any cogwheeling. I didn't have my gait was fine. I slowed down when I turned on the walk. If I kept walking without slowing down or ran into a desk, uh, never did anyone ask me about seeing a physical therapist or a speech therapist until the second visit with the neurologist, when I saw the sign on his desk that for LSVT, which is physical therapy plus occupational therapy and speech. I said, wouldn't that be a good idea for me maybe to look into that? It's right across the hall from his office. And he says, well, maybe. And I said, do you think it's better for me to do it now than when I can't walk? And he said, yeah, I guess so. But other than that, no one asked me how difficult I was having walking. No one asked me how difficult I was getting out of a chair. They watched me get out of a chair once. I can fake that. Uh, just like I faked during the last time I saw the neurologist, I remembered the clock test and I looked at the elevator to remember what floor I was on. And I remembered it was, I faked it so I could get through it. But yeah, they tell me I have MCI, but there's too much physical things going on with me for me just to say I have MCI with Lewy bodies. Uh, it's more than just your doctor's visit, but you don't have time for that to do all that. You have to have a team to work with you.
Thanks, Dr. Schmidt. Are there other comments on this portion? There are some questions in the Q&A that we can move towards. Hearing none, we'll move towards the Q&A. So the first question that came in is from Kevin, and he is asking, was there some sense of relief when the diagnosis was made, or was there a sense of loss that had to be processed after the diagnosis? Dr. Compton, you look like you have something to say.
I think there's a relief and denial both. Oh, this can't be happening. But then there's also relief that at least we're doing something, getting somewhere, getting answers.
Thanks, Dr. Compton. Dr. Langer, go ahead. Oh, you're muted, Dr. Langer.
I couldn't get any treatment until I was diagnosed. And so that was pivotal for me.
Dr. Brush.
Yeah, there was no relief for me. There was a great relief from my wife, Michelle, because now she understood some more and could understand what I was going through, because I had horrible psychological problems after I was initially diagnosed. The other thing I wanted to mention is that oftentimes you start seeing multiple doctors, psychiatrists, psychologists, and everybody wants to put you on another pill. The problem is only your pharmacist sees the interaction and how many of those pills creates cognitive change in themselves. So medication is good for some things, but yet overlying others. There's always been an argument between my psychiatrist and my neurologist, one saying, well, he shouldn't be on this, and the other one saying, well, he needs to be on this. So it's like, you're kind of stuck in the middle.
Dr. Schmidt.
When I first got the talk to the neuropsychologist, he said, you have MCI, but you're probably going to get Lewy bodies because of your disrupted REM sleep. I pictured myself in a nursing home drooling and like the patients I took care of in the nursing home. It wasn't until I saw a group of people in a support group through LBDA that I got my sense of relief. Being able to talk to people who have the same diagnosis and seeing they're doing well 5, 6, 10 years after their diagnosis.
Thanks, Dr. Schmidt. Any other comments on this question? Yeah, Dr. Dietrich.
Without a diagnosis, not only is there a problem with treatment, but I did a lot of research in my practice. So you need a diagnosis to even be eligible for any type of research, even if it's observational. So it's really critical. People don't just want an answer. They often want to volunteer and participate to help move the needle forward for others. I would like to do that, but I don't yet have a name of something to to be able to do that.
Great point, Dr. Dietrich. Any other comments on this question? All right, hearing none, let's move forward. So this question is from Nisha Garcia, and she states, as a nurse who works with people living with dementia, a physician here mentioned wanting to educate the public and professionals on how to respond to people that have dementia. Also, I heard the comment, "We are people." What can I and other nurses professionals do to make people with dementia feel less stigmatized? Go for it, Dr. Langer.
Ask them about themselves rather than just their diagnosis. You know, what defines them as a person is not whether they have renal failure or bad teeth or dementia, but rather the things they've done in their life, the things they believe in, the things that they're working towards.
Great, thanks, Dr. Langer. Go for it, Dr. Compton.
We started a support group for people with early diagnosis back in 2018. And in this conversations I have, and this is every Wednesday morning for years, we talk about things that they have in common or their past and try to stimulate past memories. It really works well because I have a couple of attorneys in there that keep telling the same courtroom stories over and over again, but it gets some like pressure and try to recall things. This just backs in on what Sarah was saying. It's the same thing, that get away from the healthcare, find out them.
Thanks, Dr. Compton.
I think a lot of people are afraid to talk to a person once they say they have a dementia. They're afraid what to say. You got to treat them like you would anyone else. You got to talk to them like you would anyone else. Most of the time, we can respond. It may be a little slower. We may mess up our words, but treat them like you would anyone else.
Thanks, Dr. Schmidt. Dr. Dietrich?
Just because you have a diagnosis of a condition that's going to affect your longevity and the quality of your life doesn't mean that your purpose in life has ended. And sometimes there's, it's like, well, my life's over because I have this label. Well, that's not true. There's your purpose may shift a bit, but there's still important things left to do.
Absolutely.
And I think every one of us would say the purpose is exactly what we're doing right now at this moment.
Absolutely. Another question came through, and they state, I'm a palliative medicine geriatrician physician myself and the daughter of a retired internist. My father has shown signs of cognitive impairment for more than 10 years and has been very resistant to diagnostic testing or even the discussion of diagnostic testing. Any suggestions on how to bring this up with a fellow physician who is resistant to the conversation? Go for it, Dr. Langer.
I think that there's a number of possible approaches. One is to drill down on healthy choices. And sometimes that sounds harder than it is. I mean, insisting that somebody run a half marathon isn't in the books, but you know, beginning to do activities that get somebody out of their armchair, avoiding ultra-processed foods, looking at vascular risk factors, and that's one approach to that. And looking at what things you can modify because we know that that's so important in terms of reducing the progression even of neurodegenerative disorders. Secondly, it would be talking about how, and this really depends on the age of the individual. So I have an 89-year-old mother-in-law who has cognitive impairment. And she says, well, I don't want to live forever, but my God, When we got her off her anticholinergic medication and onto memantine, she got so much better. And so that really changed her attitude about how she viewed her life and what her capabilities are and whether she wanted to go on living. So I guess I think that changing the narrative around, oh, you've got some hopelessly progressive disorder, to this is something that we can do something about and really potentially change your function, I think it's really worth pursuing and thinking outside the box of what her father may have learned in the course of his training and practice.
Eric has two questions, so we'll start with the first one that he shared. Would any of you advocate for regular brain scans to gauge the change annually or semi-annually?
What are you going to find on the brain scan?
What brain scan? Which brain scan are you proposing and what is the purpose? I would have to say, every procedure requires some effort and some anxiety on the part of the patient and family, and not insignificantly the cost. So I think that there is a real purpose in getting periodic brain scans if you're have any question about the diagnosis, or whether you think that your therapeutic intervention may augment a change. If you think that you need to get a sense of where things are going or they're progressing, and you want to see if there's additional atrophy, by all means, but I think you have to pose a thoughtful question about what you hope to answer with these scans.
He did clarify to say a CT scan to see
No.
shrinkage.
No.
Any other comments? Is there a different scan that you would recommend more frequently?
So I've had every scan you can do: a metabolic PET, amyloid PET, tau PET, DAT scan. None of those have been diagnostic. The metabolic PET showed hypometabolism of the cerebellum, which is curious. An MRI is a little challenging because I have a pacemaker. I have to go through extra steps, but I'm willing to have any test that the neurologist thinks might be helpful in leading to the diagnosis. So fortunately, it's through a study. I'm grateful for that. Otherwise, there could be a great cost.
So Dennis, if you knew you were progressing, and after a couple of years, would you want to perhaps repeat the FDG PET, given the fact that it showed some abnormalities initially?
I actually get that every year.
Okay.
So yes. Whatever they think would be helpful, either for me or for the observational data that's being developed, because I wanted to contribute to that. And someone asked about end-of-life plans. When I die, I'm donating my brain for pathological examination to help others in this study. So that's my goal. Not soon, but when that happens.
I don't think the scans are going to help you as much as asking them how they're doing, what's happening in their life. To do a scan as a screen, whether it be an MRI or a CT scan, I don't think that's the right approach before the diagnosis is made. You need to talk to them, need to listen to what their function is. The neuropsych testing will help some, but you really have to talk and listen to them.
To me, part of the basic thing, and I know some people that I know, is who's reading the scan. Because oftentimes a general radiologist is not going to know what to do on a brain scan. And even then,
we all know somebody who had several brain scans and studies done in the state they originally were living in, but when they moved, the doctors there said that there was nothing wrong with them. And these were the top people in neurology.
Thanks, Dr. Brush. The second question is he's asking, are you interested in doing clinical trials or taking medication that has just recently been approved?
I'll take that one quickly. For me personally, I'm at the point that I'm not willing to really take part in anything because I don't care anymore what's going to happen. I have a diagnosis. It may change, but there's no treatment to really do anything about it. So, so that's my statement towards it for me.
Anyone else?
It would depend on the risk-benefit ratio. If there's great risk, then I would be a little bit hesitant. If the risks are relatively low, I would be glad to participate in a interventional treatment. I'm in an observational study now, but would love to have the opportunity to have some potential intervention.
Thanks, Dr. Dietrich. Dr. Langer?
I think my answer would be yes and yes. Depending on whether, what the, if it was an interventional trial, what the intervention was, because I've done enough research into what the condition is, I have a sense of what might be useful and what might not be.
Thanks, Dr. Langer. Dr. Schmidt, Dr. Compton?
I think the danger of going into a trial like that is they may want to stop the medications that we're taking now. And I'm afraid that I think I'm doing pretty good. I'm slipping, but I'm doing pretty good. And if I stop the medication for a period of time, I'm going to fall back down to where I was earlier.
I agree with the above. I would prefer not to be in an aggressive interventional trial, observational trial. Fine.
Thanks, Dr. Compton. Another question, and it is asking more so the question is, someone mentioned the fear of winding up drooling and staring out the window in a nursing home, and they're asking the question, have you considered alternatives such as going overseas, Switzerland, to take matters into your own hand? Dr. Langer, I thought you might want to answer this.
Yeah, so as a person who is a member of a family with at least 3 affected generations, and my sisters and I watched my grandmother and my father become ill and die from dementia with Lewy bodies. My youngest sister elected to go to Switzerland nearly 2 years ago now. She had another really serious medical condition, which would have required many, many hours of surgery. And her observation was that my father, having undergone prolonged surgery, and my grandmother having undergone prolonged surgery, never got back to their cognitive baseline prior to surgery. And so that wasn't acceptable to her. So in the face of, this sort of situation, she elected to go to Switzerland. And my sister, who accompanied her, the only unaffected member of our sibship, said it was the most peaceful, easy thing. And I know my sister, who called me repeatedly during the course of the interviews and process, also felt extremely positive about the process, the one who underwent euthanasia. So I would say that I would consider that as an alternative to the really extraordinarily strenuous burden it puts on caregivers to take care of somebody with Lewy body. And in my family, people live with very serious impairments for many, many years before they perish.
Thanks, Dr. Langer. Other comments?
I would say that I consider my life to be a gift of God, and I would not feel for myself that that would be the right answer. But I do hope to have some control over where I am when I die eventually. And I have an advance directive, and it says what things I would want and what's important to me. And I'm also blessed to have long-term care insurance, just in case that's needed. So I'm grateful to have that because it's very expensive if you can't live in your home or need additional help.
Thanks, Dr. Dietrich. We're winding down, and there is one question left, so I'm going to pivot quickly, if I may, and then pass it back to Dr. Chodos here in 2 minutes. So the next question, the final question is, it was mentioned that when you look for resources, it's mostly for caregivers and not tips to help live independently. Have you found resources to help, or what tips have you each found helpful to manage symptoms?
An app that records everything that I plan to do tomorrow, next week, next month, everything goes in there. So I less have to forget things like this meeting. I would have forgotten it if I hadn't had it in my app.
Thanks, Dr. Dietrich. Go ahead, Dr. Compton.
Yeah, I held up my iPhone. I mean, when we first started a support group work, we made a point of use what we have, use the technology you have. And this, I can't live without this as far as navigation, remembering meetings, keeping up with things. It's just a great tool. And I think that's just really important to remain independent.
Great.
Now, if I could have a car that would drive me without me having to help, that'd be, I'm still waiting.
Sounds good. Any final comments? I do want to mention in the chat here, I'm posting a checklist that the physicians have created, and it's a dementia symptom checklist. Bear with us. We're in the process of doing some updates and making some transitions and making it more user-friendly. But this is a very comprehensive tool that the physicians have pulled together to help with that diagnostic process. And with that, it's 12:59, so I'll turn it back to you, Dr. Trodos.
Gary, thanks for sharing that. We got a nice blurry version, but if you guys are comfortable with it, we can share that with the webinar slides as well. And I did see it, and it's fabulous. I just want to thank you all from the bottom of my heart as a colleague, as a clinician, as someone trying to do very similar work. Thank you for sharing your experiences. I don't think anything sticks with people as much as hearing it from people living with dementia. And on top of that, colleagues who know what we're going through on the clinical side, trying to provide better care, but also still catching up with you and the things that you need. The gratitude was copious in the chat and the questions. So I think all of us are really, really grateful. Just thank you so much. And to reflect on a couple of things I heard, the diagnosis helped you. It helped you make a plan. It helped you address your symptoms. It helped you find support. It helped you name things. It helped you get into trials and to treatment. It is not irrelevant. Support groups were really helpful, finding other people going through what you're going through. Stigma is there. It's an issue. Denial is there. It's an issue. Listening to your patient, listening to their family, trying to get those stories, trying to understand what's really going on was really important. And we will keep talking. So thank you. I want to respect your time and that of our guests and attendees here. Thank you, everybody, for joining today. Thank you to the National Council of Dementia Minds and to all of you for doing this work.